Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast, your on-the-go source for radiology board review. On this episode, I will present part 2 of my discussion on central nervous system masses. I will make a free downloadable study guide on this topic available on my website, theradiologyreview.com, so check that out if that is something that might be helpful for you. These study guides are essentially my show notes for these episodes and will allow you to revisit the questions and answers that we will be discussing. Without further delay, let's go ahead and get into the questions and answers. The first question is this: do pituitary adenomas enhance more rapidly, or do they enhance slower compared to normal brain? The answer is that pituitary adenomas enhance more slowly compared to normal brain. Thus, pituitary-specific protocols generally have delayed post-contrast imaging to aid in evaluation of pituitary adenomas. Next, what are common differences between craniopharyngiomas in an adult versus craniopharyngiomas in a child? For a craniopharyngioma in an adult, the papillary type is most common, and papillary type of craniopharyngiomas typically do not calcify. Papillary type craniopharyngiomas are also capsulated lesions, so they are easier to resect, and these are also more solid. For the pediatric age group, they tend to have adamantinomatous craniopharyngiomas, that's kind of a mouthful, adamantinomatous craniopharyngiomas, and these do not calcify typically. These also may not be capsulated, and so they can be harder to resect, and these are the ones that have your classic machinery oil appearance. Machinery oil is a buzzword for craniopharyngiomas, and the machinery oil type of craniopharyngioma would be most common in a pediatric age group. And these also tend to be more cystic type lesions because they have these cystic spaces that hold that machinery oil-like substance. Go ahead and Google image search or look in your favorite textbook or other source to see different imaging appearances for craniopharyngiomas, and realize that there are some important differences in craniopharyngiomas depending on whether the craniopharyngioma presents in an adult with the papillary type or in the pediatric age group with the adamantinomatous type. Craniopharyngiomas, regardless of subtype, are partially solid and cystic lesions, which sometimes tend to be more cystic in the pediatric group, more solid in the adult group, and these are also typically low-grade lesions, regardless of subtype, located in the sellar and suprasellar regions, again, regardless of subtype. Next question. Meningiomas classically show uptake on what nuclear medicine studies? Note that I said studies like plural. If you can think of at least one, give yourself a pat on the back. If you can think of 2, good for you. You are on track. So, meningiomas on nuclear medicine studies typically have uptake with technetium MDP, and as a reminder, that is the bone scan agent. So if you see uptake in the calvarial region on a bone scan, you need to realize that that may actually be secondary to a meningioma rather than to a calvarial osseous metastasis. Meningiomas also frequently have somatostatin receptors, which means that you might see uptake on an octreotide scan or on a gallium-68 dotatate or other somatostatin receptor PET scan. all important points for your board study, so make sure you have that down. Next question. What are common differences between a CNS dermoid cyst and a CNS epidermoid cyst? Let's start with epidermoid cysts. Epidermoid cysts can be congenital or acquired after something like a lumbar puncture or trauma. Epidermoid cysts are usually located off of midline, and these typically follow CSF intensity on MRI sequences. Contrast that now with dermoid cysts. Dermoid cysts are typically located at midline with internal lipoid material, which can look like internal fat density on CT or intrinsic T1 brightness on T1 weighted images. Dermoids also have a neurofibromatosis type 2 association, which means they are more likely to be congenital, whereas epidermoid cysts may be congenital or acquired after something like lumbar puncture or trauma. So if you see a history in a question stem stating lumbar puncture or trauma, and they show you a mass that is typically located off of midline, you should be thinking epidermoid cysts as a potential answer to that question. Next, if you see what looks like a meningioma, but there is associated bony invasion of the skull, what additional entities should be considered? The answer I am looking for here is a hemangiopericytoma. Again, one more time, that is a hemangiopericytoma, and this is a soft tissue sarcoma that can mimic the appearance of an aggressive meningioma. Hemangiopericytomas typically do not calcify or cause hyperostosis, but these do often invade the calvarium. So if you see invasion of the calvarium with something that otherwise looks like a meningioma, you need to be aware that imaging cannot differentiate between a meningioma or a hemangiopericytoma, and both are on the differential of that entity. Next, in what age group do atypical teratoma/rhabdoid tumors most commonly present? I think this might be the first time on my podcast episodes that I've mentioned atypical teratoma/rhabdoid tumors, and these are commonly abbreviated AT/RT tumors. So again, the question, in what age group are AT/RT tumors most commonly present? The answer is that these are pediatric lesions, which typically appear under 2 years of age, but certainly under something like 6 years of age, so often very young children. ATRT tumors are high grade, unfortunately, and they often present as large tumors with internal necrosis and heterogeneous enhancement, which may be in a supra or infratentorial location. But these ATRT tumors are most common in the cerebellum. On imaging, you cannot tell the difference between a medulloblastoma and ATRT, so differentiating between these requires tissue sampling and pathology for diagnosis. Next are desmoplastic infantilegliomas, more commonly supratentorial or infratentorial. And I will be going through several of these location questions because those can be some of the quickest ways on neuroradiology questions to narrow down your differential for board exam purposes. So again, are desmoplastic infantilegliomas more commonly supratentorial or infratentorial? The answer is that desmoplastic infantilegliomas are classically supratentorial only lesions. These are large cystic tumors in a superficial cortical location. Desmoplastic infantilegliomas commonly present with a rapidly increasing head circumference in an extremely young child, often before the first birthday. So if you are given a clinical history of a less than 1-year-old with rapidly increasing head circumference, and you are shown a large cystic tumor in a superficial, possibly cortical location, you need to remember desmoplastic infantileglioma as a possibility. Next, what is the most common location of a choroid plexus papilloma or choroid plexus carcinoma in pediatric patients and in adults? For a pediatric patient, either a choroid plexus papilloma or a choroid plexus carcinoma would be more common in a supratentorial location and most specifically in the lateral ventricle. For an adult, a choroid plexus papilloma or carcinoma would be more common in an infratentorial location in the fourth ventricle. Next question. What is the most common brain metastasis in pediatric patients? The answer here is neuroblastoma. The neuro in neuroblastoma can help you remember that these metastasize very commonly to the brain in pediatric patients. 3 common sites of metastatic disease with neuroblastoma are the bones, the dura or brain, and the posterolateral orbit. Next, if you see a cyst with a mural nodule in the temporal lobe of a teenager with epilepsy, which tumors should you think of first? First, I think you should probably consider a ganglioglioma, which may present with a cystic and solid mass with calcifications essentially anywhere and in any age range, but classically in the temporal lobe in the setting of temporal lobe epilepsy. The differential for this would include other cortical-based tumors, so remember the mnemonic DOG, D-O-G, for cortical-based tumors that I reviewed in the prior episode, and for review, that is DNET for D, oligodendroglioma for O, and ganglioglioma for G. These are all cortically based tumors. Note that ganglioglioma is different from a desmoplastic infantile glioma that I discussed a few questions ago, and the classic history for a desmoplastic infantile glioma, as we said, is rapid head enlargement in a pediatric patient under 1 year of age, whereas with a ganglioglioma, a classic history may be a temporal lobe mass in a patient with temporal lobe epilepsy. Note also that you cannot tell a DNET from a ganglioglioma on imaging, so that would be a pathologic diagnosis. Next, what is the most common location for a pleomorphic xanthroastrocytoma, or PXA? Again, that is pleomorphic xanthroastrocytoma with an X for xantho. What is the most common location for this? The answer is that pleomorphic xanthroastrocytomas are always supratentorial and usually located in the temporal lobe, also presenting with a cyst with mural nodule. These may show in dural tell, and these tumors are also common in the setting of epilepsy or seizures. Next, true or false, a PNET, that is P-N-E-T, which stands for primitive neuroectodermal tumor, appears similarly on histology as a medulloblastoma. Again, is this true or false? A PNET, P-N-E-T, appears similarly on histology as a medulloblastoma. This is true. These entities can look very similar on histology. However, a PNET is a supratentorial lesion, and these have been nicknamed a supratentorial medulloblastoma. Unfortunately, PNETs, PNETs, have a very bad prognosis due to the propensity to have distant metastatic disease. Next, what is the classic imaging appearance of a medulloblastoma? Medulloblastomas commonly present as a midline mass centered at the roof of the fourth ventricle with associated hydrocephalus. Remember that roof of the fourth ventricle is a classic descriptor for things like a medulloblastoma. Next, what tumor is classically associated with gelastic seizures? If you haven't heard of that yet, that is Gelastic, gelastic. So what tumor is classically associated with gelastic seizures and precocious puberty with a mass in the tuber cinereum? If that is not enough for you to get the correct answer, you simply do not know this, because that history should guide you immediately to a hypothalamic hamartoma. If you don't know that yet, now is the time to get it down. Hypothalamic hamartomas. This is a hamartoma of the tuber cinereum, and these typically do not enhance. And this is separate in location from the pituitary stalk, so it really is its own entity here. Gelastic seizures are seizures that are associated with something like a sudden onset of laughing or some other form of a sudden release of energy, such as yelling or something like that. But most classically, it would be a seizure that has a sudden onset of laughing. That is a gelastic seizure, and that is associated with a hypothalamic hamartoma. Next, what is more common in the spine, a medulloblastoma or an ependymoma? The answer here is that a medulloblastoma is much more common than an ependymoma. Medulloblastomas of the spine tend to restrict on diffusion-weighted imaging and have something called Zuckerguss, which is a German word, Zuckerguss, Zuckerguss, which means sugar icing, and it is named that because that is how the leptomeningeal spread or coating of the leptomeninges appears on a contrast-enhanced imaging, where you see this fine superficial enhancement like icing over the spinal cord and nerve roots. Ependymomas are more likely to calcify than medulloblastomas, so tuck that away. And to answer this question, medulloblastomas are much more common in the spine than an ependymoma. Next, can you name at least one syndrome with a medulloblastoma association? Now, there are probably many syndromes that have medulloblastoma association, but at least two that I think should come to mind are the basal cell nevus syndrome, which is also known as Gorlin syndrome, Gorlan, and basal cell nevus or Gorlin syndrome presents with a medulloblastoma, dural calcifications, basal cell skin cancers, and odontogenic cysts, and these are common in a patient who has had prior radiotherapy. The other condition I think you should remember in terms of medulloblastoma association is Turcot syndrome, Turcot, Turcot syndrome. And this was actually discussed in episode 1, so if you listen to that episode, perhaps you remembered that. Turcot syndrome is classic for GI polyposis, that's gastrointestinal polyps, and brain tumors, which most commonly include a medulloblastoma and or a glioblastoma. Next, with a vertical gaze palsy, which is also known as Parinaud syndrome, Parinaud, what tumor is most classic? The answer here is that a tumor of the pineal region can cause vertical gaze palsy, which is also known as dorsal Parinaud syndrome. Next, and along these same lines, what is the most common pineal tumor? And that is pineal, pineal tumor. The answer is that a germinoma is the most common pineal tumor. In general, girls are much more likely to have a suprasellar germinoma, and boys are most likely to have pineal germinomas. Remember that difference in germinomas between girls in the suprasellar location and boys in the pineal region. Now that is a general rule, not an absolute rule. Note that germinomas can cause precocious puberty via HCG secretion, so tuck that away as well. Next question, can you name some other pineal region tumors? And what are some basic differences between these pineal tumors? Besides a pineal germinoma, there is also a pineocytoma or a pineoblastoma. So, what are some basic differences between a pineocytoma and a pineoblastoma? For a pineocytoma, these are uncommon in childhood, and these are typically non-invasive, whereas pineoblastomas are actually more common in childhood and highly invasive, unfortunately. So one simple mental trick I have to keep this in mind is that a pineocytoma hides out of sight of children. CYT for cytoma and sight. I don't know if that works for you, but it does for me. Pineocytomas hide out of sight of children, whereas pineoblastomas are common in children because kids frequently have a blast, like the blast in pineoblastoma. If that works for you, go ahead and use that. Next, what is the so-called trilateral retinoblastoma? Trilateral retinoblastoma is when you have bilateral retinoblastomas and a concurrent pineoblastoma at the same time. So you have 3 tumors, 2 of which are retinoblastomas bilaterally, and a concurrent pineoblastoma. Pineoblastomas and retinoblastomas are both small round blue cell tumors, and they are associated with one another. And if you see 2 retinoblastomas and a concurrent pineoblastoma, that is what is termed a trilateral retinoblastoma. Final question for this episode. What is the significance of pineal calcifications in differentiating between a germinoma versus a pineocytoma or pineoblastoma? If the pineal calcifications appear exploded, that would be suggestive of a pineoblastoma or a pineocytoma. And I remember that because pineoblastoma has blast, which can mean explosion. So I remember that if the calcifications appear that they have been blasted or exploded, that suggests a pineoblastoma or by extension a possible pineocytoma. And remember that pineoblastomas would be more common in childhood, whereas pineocytomas are more common in adults. If the pineal calcifications appear to be engulfed within the mass, then that is much more likely to be a pineal germinoma, so you can use those calcifications to your advantage when forming a differential diagnosis as you answer ABR core exam questions or questions for whatever radiology examination may be in your own particular future. That is enough for now. I will post a free downloadable study guide on my website, theradiologyreview.com, that you can download that reviews these questions and answers in written form. I wish to thank you, listener, for listening to this podcast. And I congratulate you on taking a few minutes to continue your radiology education and preparation for radiology board examinations. Remember, as always, that you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.